Thank you for joining today's crisis response training focused on continuity of care in Mississippi's crisis response system. My name is Marilyn Johnson, and joining me later in this training will be Jennifer Hodgson, and we are with Health Management Associates. HMA is a leading independent national research and consulting firm that focuses on improving the administration and delivery of public health, healthcare, and social services programs. HMA is supporting the Mississippi Department of Mental Health in its efforts to enhance the state's crisis response system by providing online training resources designed to strengthen care, coordination, and support safer transitions and stronger outcomes. And we'll begin. In this session, we will cover 3 core objectives: describing the Mississippi Crisis Care Continuum and the principles of continuity of care, identifying the roles and contributions of multidisciplinary teams that support continuity, and explore strategies to improve coordination and follow-up, particularly for high-risk individuals. We will begin with the first objective: describing Mississippi's care continuum and defining what we mean by continuity of care. This diagram provides a high-level overview of a comprehensive crisis system. It begins on the left with outreach and early intervention services, then moves through active crisis response services, such as call centers, mobile crisis teams, and crisis stabilization. And it ends with post-crisis support. These components are designed to work together so that individuals receive timely and effective care across every stage of a crisis. In Mississippi, this includes 988 call centers, regional crisis response teams, crisis stabilization units, and follow-up services provided by community mental health centers and other partners. A strong crisis system does not rely on one agency or one team. It requires coordination across multiple organizations, businesses, schools, law enforcement, EMS, healthcare providers, and others. Mississippi's system has evolved over the years through a combination of leadership, legislation, and collaboration. Some of those key milestones include the development of crisis stabilization units around 2009, 2010, expansion of mobile crisis teams in 2014, implementation of 988 in 2022, and the passing of House Bill 1640 in 2024, which advanced mobile response legislation. These efforts represent a journey towards a more coordinated, person-centered response to mental health crisis. If you would like to learn more about Mississippi's progress, we encourage you to visit the Department of Mental Health's website, where you can find additional trainings, including a session led by Director Bailey that goes into more detail about the state's crisis system's evolution. What is continuity of care? Now let's shift our focus to continuity of care. The Substance Abuse and Mental Health Services Administration, SAMHSA, defines continuity of care as a process that ensures clients receive coordinated, uninterrupted care across time and services. So this is not a technical process. It reflects a commitment to follow through, shared responsibility, and continuity of care involves warm transitions, ongoing communication, sustained support, and especially during vulnerable moments in someone's recovery journey. Let's break that down a bit further. Continuity of care is not a one-time referral. It is not a handoff with no follow-ups. And it is not a disconnected system where each provider works in isolation or a silo. Instead, it looks like things that we kind of briefly touched on in the last slide: warm handoffs, direct communication, a shared understanding of the individual's needs and plan of care, ongoing support that helps build trust and accountability. It's about making sure no one is left to navigate their recovery alone, especially when they are in a crisis. Continuity of care matters for several reasons. It builds trust and safety, which are essential for engagement in care. It improves follow through, ensuring that people actually connect with services after a crisis. It reduces risk of preventing people from falling through the cracks during transitions between programs, facilities, and systems. And without this continuity of care, even the best services can fall short if they are not connected in a way that supports the person throughout their journey. To help illustrate these concepts, we will refer to a case scenario throughout the training. Let's meet Jamal. Jamal is a 29-year-old African-American male with a history of bipolar disorder, substance use disorder, and frequent emergency department visits. He is uninsured and recently evicted with limited family support. So one day after exhibiting erratic behavior in public, Jamal is brought to the emergency room by law enforcement. He's evaluated by a mobile crisis response team and admitted voluntarily to a crisis stabilization unit for 5 days. While there, he received medication, peer support, case management. However, once discharged, there is uncertainty about whether he will remain connected to care. As we move through the training, we will return to Jamal's experience to highlight real challenges in care transition and to identify what strong continuity can look like. Mississippi's alignment with SAMHSA's foundational principles basically goes into, someone to contact, someone to respond, somewhere to go, and someone to follow. Now, as we think about those principles and we apply those to continuity of care, we think about Jamal, we can begin to consider a few questions. Who was responsible for his follow-up? Did Jamal receive a warm handoff to community services? Was there a coordinated plan for supporting his transition back into the community? So we think about how the system responded to Jamal, what worked, what was missing, and we think about the foundational principles. All of those things should exist in the continuity of care. We'll refer back to Jamal as we talk about crisis services as well, common breaks down in continuity, and stages for improvement. Let's take a closer look at where continuity of care can break down. Many of the challenges Jamal faced, like uncertain follow-up, lack of coordination, are common across systems. They can derive from miscommunication, those unclear roles and expectations, incomplete or delayed transfer of information, barriers to referrals, including lack of transportation, mistrust or lack of engagement due to prior experiences. All of these breakdowns don't always happen in isolation. Many of them don't. Often it's the combination of small gaps that creates risk and contributes to poor outcomes. Now let's turn our attention to the antidotes, the strategies that help prevent the breakdowns we discuss. This slide lists common gaps that can disrupt the continuity of care: lack of follow-up, miscommunication, role confusion, disjointed care, misreferrals, and lack of trust. All of these things we're familiar with, but when they happen to a person who's in crisis, that makes the challenges more severe. So these challenges often appear in real life cases like Jamal's. And as many of you know from experience, it's rarely one issue on its own. It's the combination of small gaps that can result in people falling through the cracks. So if you'd like to pause here for a moment and reflect on your own experience as a crisis responder or member of a crisis care system, what are the antidotes you've seen work in response to these issues? What would it take to apply these antidotes more consistently across your community? And we'll explore more concrete strategies in the next part of the training. As we prepare to move into the next section, keep Jamal in mind. His experience represents the kind of real-world challenges that individuals face every day when navigating our system. In the next part of the training, Jennifer will explore how multidisciplinary teams play a key role in strengthening continuity, and she will also share real examples from Mississippi and walk us through actionable strategies you can apply in your role. To close out this portion of the training, I want to leave you with this reminder. Continuity of care is not a checklist. It's a mindset and a commitment. When every provider takes responsibility for ensuring a smooth transition to the next step in care, we can reduce the risk and increase the hope. Thank you for being a part of this work, and I'll now turn it over to Jennifer, who will continue with our remaining objectives 2 and 3.
Right. Here we go. Thank you, Marilyn. So for the second objective, we're going to cover the role of multidisciplinary partners in supporting care transitions. It's important to know the vital roles and brief descriptions of each multidisciplinary crisis response system partner's contributions. Let's go through them together. Mobile crisis team's primary function is to provide on-site de-escalation, triage, and referrals to individuals in crisis. Another role is law enforcement. Law enforcement links to crisis services and may respond or co-respond, offering their security, support, and expertise in known or unknown physically unsafe situations. The third are emergency departments. They offer immediate stabilization, medical clearance, and then refer individuals to the appropriate level of care. In the case of Jamal, the hospital emergency department played an important role in contacting the mobile crisis response team, which then determined that Jamal met the criteria for further evaluation, but was not an immediate threat to himself or others. The next are crisis support units. These offer short-term stabilization, psychiatric evaluation, and discharge planning for individuals needing a more intensive level of care than outpatient intervention and who may not need inpatient psychiatric care for a longer period of time. Actually, pause. I think I said. It's important to know the vital roles and brief descriptions of each multidisciplinary crisis response partner. Let's go through them together. The first, mobile crisis teams. Their primary function is to provide on-site de-escalation, triage, and referrals for individuals in crisis. The second is law enforcement. They link to crisis services and may respond or co-respond, offering their security, support, and expertise in known or unknown physically unsafe situations. The third are emergency departments. They offer immediate stabilization, medical clearance, and then refer individuals to the appropriate level of care. In the case of Jamal, the hospital emergency department played an important role in contacting the mobile crisis response team, which determined that Jamal met the criteria for further evaluation, but was not an immediate threat to himself or others. Next are crisis stabilization units. They offer short-term stabilization, psychiatric evaluation, and discharge planning for individuals needing a more intensive level of care than outpatient intervention and who may not need inpatient psychiatric care for a longer period of time. Jamal was voluntarily admitted to a crisis stabilization unit for a 5-day stay. During his stay, he was stabilized on medication and met with a peer support specialist and a case manager. However, his long-term engagement in care was uncertain due to multiple social barriers. Therefore, the involvement of the Community Mental Health Center is a critical next step in the continuum of care for Jamal. The next are community mental health centers. They offer long-term outpatient care and case management support to individuals post-crisis. Next are peer support specialists. They provide lived experience support and build trust with individuals during or post-crisis. Individuals needing peer support specialists can contact their local community mental health center. Next are housing and social services. These individuals help to address social determinants of health factors that may be exacerbating behavioral health crises. And last but not least are family members and caregivers. They are important partners during and post-crisis as they offer important history on the individual and their contextual factors, and they help to advocate for and support the follow-up of continuity of care services along the behavioral health continuum. Now, we're going to talk about some examples of multidisciplinary partnerships in Mississippi. Mississippi has several excellent examples that highlight the critical impact that multidisciplinary partnerships have on a successful crisis response system outcome. One example is in Region 2, Northern Mississippi, where mobile crisis teams are co-responding with sheriff's departments, diverting individuals from jail to crisis stabilization units. This is resulting in the reduction of arrest rates and improving connection to treatment. A second example is how the Mississippi Department of Mental Health mandates that crisis stabilization units provide discharge planning that includes a face-to-face appointment with a community mental health center interventionist within 7 days of discharge. This action is reducing lapses in care and returning to a crisis state without connection to ongoing care. It is also aligned with a national best practice standard. A third example takes place in Region 12, the Pine Belt. Stakeholders implemented a care coordination platform where mobile crisis stabilization units, and outpatient providers can update a client's status in real time. This is reducing duplication of services and is improving continuity of care. Let's dive into some best practices endorsed by SAMHSA, Substance Abuse and Mental Health Services Administration, that support continuity of care in the crisis response system. First is the warm handoff. This describes how in real time, as individuals' care is transitioned from one person to another, and it's not just a cold referral put in where there's a greater risk of no follow-up or connections being established. These are person-to-person experiences. Second is the development of shared care plans. These are plans that offer clear, coordinated action between agencies that outline the responsibilities of each partner and the next steps in the crisis care experience. Another best practice element is the use of peer supports. These are trained individuals with lived experience that help build trust and ease engagement across the crisis service partners. It is possible that Jamal, after establishing care with the Community Mental Health Center, would be paired upon his consent with a peer support specialist who can play a vital role in supporting him in crisis avoidance and his engagement with ongoing and continuous mental health and social service supports. You will hear us stress the importance of coordination and collaboration in supporting transitions between crisis response partners. This is because transitions are vulnerable moments for individuals in crisis, and poor coordination can lead to missed follow-up appointments, medication lapses, repeated emergency department visits or arrests, returning to crisis state, and civil commitments. In 2020, SAMHSA found coordinated transitions reduce psychiatric rehospitalization and improve medication adherence. In Jamal's case, if the police did not recognize his mental health issues and only saw his substance use history, they could have arrested him and taken him to jail, where his mental health and substance use disorder needs would not be the priority concern in that system immediately. To achieve the level of coordination and collaboration needed in a crisis response system that is aligned with best practice, cross-training of each multidisciplinary partner is critical. Mississippi's Department of Mental Health understands that, and that is why these trainings have been developed. The benefits of cross-training include helping non-clinical staff, which are housing case managers, peers, transportation partners, and many others, understand the behavioral health needs of individuals exiting a crisis, and educating clinical teams about community resources and culturally competent approaches for high-risk or underserved groups. A 2022 NAMI report recommended cross-training as a best practice in crisis response infrastructure development, particularly in rural states like Mississippi, where workforce limitations necessitate greater role flexibility. For example, including law enforcement officers in mental health first aid and trauma-informed care training help prepare them to best address the needs of an individual in crisis when serving in a direct or co-responding role in their communities. Now let's move to the third and final objective. Here is where we will cover strategies to strengthen coordination, communication, and follow-up, especially for our high-risk population members. To support transitions, crisis response partners work to communicate clearly and in real time, and when possible, through the use of shared electronic records, standardized referral forms and release of information protocols, and weekly case coordination meetings, especially between the community mental health centers, crisis stabilization units, and mobile teams. When serving the crisis care needs of high-risk and underserved populations, it is about serving those who are disproportionately impacted by mental health crises, yet often have less access to care due to geographic isolation or their rurality, poverty or uninsurance, stigma and mistrust, and language or cultural barriers. In Mississippi, rural communities, African American residents, people experiencing homelessness, the uninsured, and justice involved individuals are overrepresented in crisis encounters but underconnected to long-term supports. Mississippi ranks among the bottom 5 U.S. states in access to mental health care due to a lack of insurance coverage, with rural counties facing the most severe shortages of mental health professionals. When responding to the crisis care needs of unique populations, it is important these responses are tailored. This includes the positioning of crisis response services to be culturally responsive and trauma-informed. Services should adapt to language differences, cultural norms. For example, mental health concerns are sometimes viewed in African American communities as personal weakness, spiritual failure, or something to be handled within the family or church. Among Latino families, there's a strong emphasis on family, familismo, and mental health issues may be addressed within the extended family before seeking outside help. Among older adults and rural populations, there is a preference for self-reliance and stoicism or minimalization. Therefore, help seeking may be viewed as a last resort. So these are all examples of cultural norms, and it's important to ensure services and responders are prepared to recognize and meet the needs of individuals with co-occurring conditions, whether physical and mental health or multiple mental health comorbidities. So as you can see, there are oftentimes layers of things that stand between individuals and care, and training all of our system members to recognize these and to know how to help walk through them is a critical part of our cross-training curriculum. In Mississippi, some community mental health centers incorporate faith-based organizations and peer support specialists to build trust and reduce stigma among marginalized groups. So some agencies are bringing in these resources so that they can have direct care and involvement for those who need it to really gain that trust and begin to break down some of those barriers. This slide we are using to support you by providing several tools. These tools will help in the optimization and coordination and communication and even the follow-up in crisis care response. They've been endorsed by SAMHSA and the National Council for Mental Well-Being. The first is the Encounter Log. And this is in SAMHSA's Crisis Counseling Assistance and Training Program Toolkit. This encounter log can be used to track client contacts and referrals, so they are oftentimes reducing the amount of missed follow-ups that happen. The next is the assessment and referral tool, and this helps determine the level of care needed during and after a crisis, so we're better able to deliver the right care at the right time for that individual. Then there's the weekly tally sheet. This is used to track the volume of crisis service activities to monitor gaps so that we can make really informed changes in the crisis response system based on trends and what the data is telling us. And then the shared care template, which can be used to align multiple providers around transition follow-ups so that we're all feeding into a similar care plan, reducing duplication and increasing and improving outcome. We invite you to pause this training and think about a time when a client or loved one slipped through the crisis response cracks. Let me start that over. Pause. We invite you to pause this training and think about a time when a client or loved one slipped through the crisis response cracks, where a transition to care was not done well. Think about what could have prevented it. What can your team do differently to support better transitions? While some issues do not have easy solutions, there is creativity among all team members. It's important to ensure that all ideas rise to be heard. After you have completed this exercise, unpause the training and continue. Some key takeaways from this training are the following. Continuity of care is about follow through, not just discharge, so that people like Jamal feel the support of the system from beginning through to follow through. Everyone plays a role in making the transition safer. There are practical, proven tools that you can begin using today to help improve coordination and collaboration and follow through. And improving continuity improves outcomes. This slide includes references that you can use to support your continued learning and development. This list supports Mississippi's commitment to its crisis response system and multidisciplinary partners working effectively through coordination, communication, and cross-training for a seamless service delivery. Thank you for completing this module with us today. A training library is being developed that's starting in May 2025 and will be developed through June 2026. We're compiling recorded and accessible resources to support you in your role. Frequently check the Department of Mental Health's website that is linked on this slide for updates and new training uploads. Here's a list of some of the training topics and trainings that are being recorded and that will be housed on the Department of Mental Health's website that was referenced on the previous slide. As you can see, some of the things that we talked about today are gone into significant depth in some of those trainings. Please make sure to follow us on social media platforms such as Facebook, YouTube, and Instagram. And thank you for your participation and have a wonderful day.